Hello, my name is David Dale, and I'm Professor of Medicine at the University of Washington and President of Alpha Omega Alpha, the Honor Medical Society. On behalf of Alpha Omega Alpha, I'm pleased to introduce taped interviews with leaders in American medicine. This series was begun in 1970 with a generous gift from David and Beatrice Siegel, professors at Columbia University's College of Physicians and Surgeons. The goal of this series is to preserve for us and for future generations the experiences, the ideas, and the vision of distinguished American physicians and surgeons. It gives me great pleasure to introduce leaders in American medicine.
Well, Pat, this is a very special occasion. We're meeting here on the 25th anniversary of your appointment as the professor and director of the Brady Urological Institute at Johns Hopkins. And we're meeting right in the historic Hugh Hampton Young Library in a building that really did not exist when you first came here in 1974, but represents the cumulative effort of 25 years of enormous work and contribution to the field. I've been here for a good deal of that time, and I've had a chance to see your career blossom and become one of the most distinguished urological careers of this century. You've made many very significant discoveries. You have been recognized and honored for your contributions. You've received the Kettering Gold Medal from General Motors for your work in cancer. You've been appointed to the editorial board of the New England Journal of Medicine. You are the editor-in-chief of Campbell's Urology, the leading world's textbook for urological science and surgery. And you have led this department to a position of being recognized as the leading department probably in the world for at least the last 10 years, if not longer. This is truly an outstanding achievement, and we're here to both honor that and to hear from you today about that experience. When you reflect back on all these years, what sorts of things do you think about?
Well, I've been very lucky. I had wonderful parents who instilled a great religious philosophy in me. I was very lucky to get married to a wonderful woman, have 3 sons. I had a great education. I had a number of mentors. And together, the element that maybe made the biggest difference was luck. And I'll talk about that today in a couple of ways, whether it's chance or whether it's timing. But certainly that was a critical element that put all of these other elements together for me.
Let's start by going back to Akron, Ohio, which is your hometown and the place where you were born. Tell us about your childhood.
I grew up in Akron, was born in 1938, the second of 4 children to wonderful parents. They didn't have a lot of resources, but what they did have, they gave to their children. There was a very strong religious belief in my family, which was supported by my education. I went to preschool and to grade school and to high school, to a school that was taught by Dominican nuns. And in my life, I've had a lot of peers who were better educated, more talented, smarter. And when I look back on the fact that I've been able to make some accomplishments, I trace it back to that education I had and that support from my parents. I was taught every day why I was on this earth, and it was to use the gifts that God gave me to help my fellow man. From the time I was about 3 years old, I wanted to be a doctor. There's even a picture of me with a stethoscope around my neck when I was about 3. And I had a mission, and I really knew why I was on this earth. And I think that's what's made the difference. I've not strayed from that path very far at any time in my life. And some of my friends who were maybe better educated, had more talents, didn't contribute as much, possibly because they became confused about why they were here. At one point it was to make a contribution, then it was to have a good time, and they strayed back and forth, never really having a focal point. And maybe that's made the biggest difference in my life. In addition to that, I had a wonderful uncle. Now, my father was great, but my father wasn't interested in science. But I had an Uncle Harry, my mother's brother-in-law, who graduated from Carnegie Tech as an engineer and returned to Akron to run his father's plumbing business. And that never satisfied his scientific curiosity. And so beginning about when I was 7 years old, my uncle and I went out every Sunday afternoon for a hike. And we found Indian relics, or caught turtles or snakes, frogs. We built transmitters. One summer we took a Geiger counter to Canada to find uranium. And it was that contact with him that really stimulated my scientific curiosity. His wife was also a nurse, and so Sunday night I had dinner with her. It was a chance to talk about medicine because there was no one else in my family that was interested in medicine. And I'll tell you a small story that'll mean more as we get on in this discussion. But my Uncle Harry loved to teach me big words. And one of the words he taught me was the auricular-ventricular bundle of His. So here I am at 8 years of age learning this as the conduction bundle in the heart. And I remember picking up my aunt's nursing dictionary to find out what the definition was. And I learned that the definition of the auricular-ventricular bundle of His was the neuromuscular bundle between the auricle and ventricle. And it's really ironic that the neurovascular bundle is what I discovered later in life, and that had great meaning. My Uncle Harry lived long enough so that my sons could have the opportunity to take a hike with him when they were quite small. But shortly thereafter, he developed metastatic prostate cancer and died a terrible, painful death. And that was around the time when I was a resident in urology and decided to dedicate my career to the treatment of prostate cancer.
So your Uncle Harry probably lived long enough to see you go to medical school, and I'm sure that must have been a very special moment for him and for you as well. Before that, you had to be an undergraduate student at a college. Tell us where you went and what your experiences were like.
Well, my parents didn't have much money, and my brother went to Akron University, and that was where I would go unless I could get a scholarship. And my father said, you should apply to Western Reserve University because they have a great medical school. And I did. I applied to Case Western Reserve University for undergraduate school and got a full tuition scholarship and went on to their medical school, where I had an excellent education. There I came into contact with a second mentor in my life, Claude Beck, a cardiac surgeon, who went to medical school here, trained at the Brigham, came to Western Reserve, where he was the cardiac and neurosurgeon for a number of years, if you can imagine that. Developed a number of operations for coronary artery disease and resuscitated the first patient from a fatal heart attack ever. Well, he was my mentor in medical school, and I did research every summer with him, and when I went off for internship interviews, he paid for those trips. And he gave me very good advice, and as a result of that advice, I left medical school headed toward a career in neurosurgery.
So you were influenced by Beck as an undergraduate student. You were fortunate enough, and you must have done extremely well. You then went to the Peter Brent Brigham Hospital in Boston. At that time, Dr. Francis Moore was the chairman of that department, and I'm sure a very important figure also in your life. Would you tell us about that?
Well, those were great days. I picked that training program because it was a 3-year training program, 2 years of adult surgery, a year of pediatric surgery at Boston Children's with Robert Gross. And I decided that if I had changed my mind about what to do, it would be an excellent background. And during my first year, I spent 8 weeks in neurosurgery with Don Long, who is now the chairman here. And it was a great time, but it made me realize that I did not want to be a neurosurgeon. I found that the results from surgery sometimes could be disappointing. The nervous system is unforgiving to injury. And I decided that I wanted to find a field where I was more in contact with evaluating patients, treating them, following them, where patients had a good outcome, and where there was a field for research. And it surprised me that I picked urology. Now, at the Brigham in those days, there were a lot of things going on in urology. All of the adrenal surgery was done by Hartwell Harrison, the chairman there. Transplantation was very active. And so the day came after my internship when I had to see Dr. Moore. He met once a year with us to see what I wanted to do. And Franny Moore was considered to be one of the leaders in American surgery. He was the Moseley Professor of Surgery at Harvard. And he said, "What are you going to do?" And I said, "Well, I've decided that I'm going to go into urology." And he said, "Well, where do you want to train?" I said, "Well, I was overseeing Weil and Ledbetter at the Massachusetts General Hospital last week, and I've talked to him about training there." Well, Dr. Moore surprised me by saying, "Well, you don't want to train there." And when I asked why, he said, "Well, because the professorship isn't there." And I said, "Well, what difference does that make?" And he said, "Well, I want you to replace Hartwell Harrison as the Elliott Carr Cutler Professor at Harvard and the next chairman at the Brigham." Well, after I picked myself off the floor, I said, "Where should I train?" He said, "Well, you should train with Willard Goodwin at UCLA. You should do a couple of years of research after that and return here." So he picked up his dictaphone and wrote to Dr. Goodwin and said that he wanted me to go to California and train at UCLA. Well, that night I came home and Peg said, "What's new?" And I said, "Well, we're going to be moving to California and we're going to train at UCLA. We're going to do a couple of years of research and then I'm going to come back and replace Dr. Harrison as the chief of urology at the Brigham." And she said, "Did anything else happen?" I said, "Not really." No, it was really a shock because in those days, your whole life could be turned around by one person and one person's advice. Dr. Moore and Dr. Harrison lent us the money to travel across the country, and in 1967, we went to Los Angeles.
You left Boston to go to Los Angeles. It's not the place you may have imagined yourself to be at that time, but there you were, and Willard Goodwin was the chairman of the department at that time, certainly very strong roots with our own department here and his connection with Hugh Young. Joe Kaufman, who was in that department, would later become the chairman. Tell us about your experiences at UCLA and the sort of further development of your interest there.
It was wonderful to move from the East Coast to the West Coast. There were a lot of things going on in that department, like renal vascular surgery, which we don't even do today. And it was a wonderful place to train in surgery. But my big concern was doing research. And I wrote to Dr. Moore and I said, "What should I work on?" And he suggested that I work on the hormonal milieu responsible for the development and progression of prostate cancer. And actually that advice made me very happy because I was very interested in endocrinology. And this is where timing really plays a role. Dr. Scott, who I succeeded, had spent his entire life working on the endocrinology of prostate cancer. But during that entire time, from the 40s to the 70s, the tools that were necessary to dissect apart the problem weren't available. You couldn't measure serum hormones. They were looking at 17 ketosteroids in the urine, which were not an accurate measure of androgen action. But in the late 1960s, a lot of things were happening. Radioimmunoassays became available, and you could now measure LH, FSH, and testosterone. And Bill O'Dell, who had actually developed the gonadotropin assays, had just come to UCLA. The understanding of how steroid hormones worked in target tissues was also developing. And so it was a wonderful time to enter this field. So I started out working on gonadotropin physiology and a drug called cyproterone acetate, which was an anti-androgen. And within the first 3 or 4 months of my time in the laboratory, 2 big breakthroughs occurred by Gene Wilson. The first of these discoveries was that in the nucleus of the prostate, the active form of androgen was dihydrotestosterone, which was produced by the powerful enzyme 5-alpha reductase. And secondly, for dihydrotestosterone to work, it had to be bound to a receptor. Well, here I was working with an anti-androgen, and it raised an interesting question. How did cyproterone acetate work? Did it block the formation of dihydrotestosterone or binding to the receptor? So I went to Dr. Goodwin and I told him about this possibility, and I asked him if I could spend an additional year in the laboratory and take some courses in molecular biology. And he granted that wish. So I actually only had a first year of urology residency and a chief residency, and the 2 years in between I spent in the lab. Now, Dr. Goodwin felt that was justified because I had spent so much time doing pediatric surgery and indeed pediatric urology in Boston. So I entered a wonderful time of investigation and was able to show that cyproterone acetate acted by blocking binding of dihydrotestosterone to the receptor. So it proved to be just a wonderful time.
And this was a very active period in the development of your career. There are a number of things happening here. First of all, you're getting interested in Wilson's work. You're starting to do your own endocrinological work. And about this time, before you go off to Texas, you're about to go to San Diego to further develop your clinical abilities and to serve in the Navy. Tell us about San Diego and then your trip to work with Wilson.
So I finished my residency in 1971, and in that era, everyone had to serve in the military. So I was assigned as a urologist in San Diego to the officers' clinic, where I began doing radical retropubic prostatectomies. I had a small research lab, and I had met Gene Wilson, and he and I decided that it would be wonderful if I came to work with him for a year. And over the 2 years that I was in the Navy, I went back 3 or 4 times to see Gene and to set up the experiments that we were going to carry out. I went back and gave grand rounds at the Brigham, and Franny Moore was very pleased with what I was going to do. And we were all set to go to Boston, and then a big surprise came in January 1973. I was 34 years old, and Hopkins called and asked me to come and look at the job here. And shortly thereafter, I was offered the position at Hopkins, and the question was, you know, what should we do?
Who did that call actually come from at that time?
Well, the call offering me the position came from George Zeidema, who was the chairman of surgery at that time. So Peg and I came back and looked at Hopkins, and she said to me, "Pat, you have to come here." So we really turned our life around. Although we had planned to go to Boston all those years, in 1974, we arrived here.
What was it that drew you here? What was it that you think inspired your wife to recommend this place for you?
Okay. Well, I think Peg saw the tradition here. She realized that there was a tremendous opportunity, and the job was almost tailor-made. All of the other individuals who had been chairmen here were interested in prostate cancer, were interested in all the factors that made it grow, and she saw a great opportunity for our career here.
But before you came here, you still had time to spend in Texas with Dr. Wilson. You concentrate on endocrinological aspects of prostatic growth, development, and hyperplasia. And at this time, you were also thinking and preparing mentally probably to come here. Tell us about your work in Texas.
Oh, it was an unbelievable time. From 73 to 74, I was in the Department of Internal Medicine at the University of Texas Southwestern Medical School in Dallas. It was a fantastic department. Gene Wilson was really at the height of his work. He was the editor of the Journal of Clinical Investigation. Mike Brown and Joe Goldstein were down the hall doing their future Nobel Prize winning work. A very exciting environment. And during that year, Gene and I made 2 wonderful discoveries. One night, he said to me, "Let's go over to the Children's Hospital and see a young woman who was about 11 years old who was beginning to virilize." Now, let me give you some background. Gene Wilson had discovered the importance of dihydrotestosterone, and he had looked at fetal development, and he was able to show that the enzyme 5-alpha reductase, which was necessary for the formation of dihydrotestosterone during fetal life, was not in the primitive tissues that give rise to the epididymis, the vas deferens, and the seminal vesicles. But it was in the tissues that give rise to the prostate and the male external genitalia. So he reasoned that the internal duct structures were under the control of testosterone. Well, we go over to see this young lady, and we learn that her sister, at about 3 years of age, had a hernia repair. And at the hernia, a testis was found, and that testis had a normal epididymis. And so it struck us that this was the phenotype that one would expect if someone lacked the 5-alpha reductase enzyme. So Gene said to me, "Tomorrow, when this young lady is operated on, I want you to dissect out the seminal vesicles." Well, you know that's hard enough to do in an adult, much less impossible to do in the kind of operation that was going to be performed in this young lady. Well, the next day, I convinced the pediatric surgeon who was taking care of her to let me scrub in, and we did a vasogram. We exposed the testis, we saw a normal epididymis, and we injected dye, and I'll never forget when that x-ray came out, because it showed the vas deferens coming down, a normal seminal vesicle, an ejaculatory duct ending in the vagina.
And a photograph of that appears in the paper that describes that case, I believe.
That's right. So we took the tissue back, showed there was no 5-alpha reductase activity, and published that paper in the New England Journal of Medicine in the fall of '74. And shortly thereafter, individuals from the New York hospital. Imperato McGinley and Associates showed that in a large kindred of individuals in the Dominican Republic that there was the same phenotype. So it was an exciting time to show that 5-alpha reductase deficiency. The other thing we did is that we worked out the model for inducing benign prostatic hyperplasia in the dog. The only two mammals that develop benign enlargement are man and the dog. And up to this time, no one had been able to induce that disease in an experimental animal. And Gene had tried using a variety of different hormone combinations. So we reasoned that the combination of dihydrotestosterone, or one of its metabolites, and estrogen might be the answer. So we set up an experiment carefully designed to find small differences in prostate size, and we took beagle dogs and we treated them with either a 5-alpha reduced androgen, androstenediol, estrogen, or a combination of the two. And the experiment got off just as I was leaving to come to Hopkins, and I came back after 3 months. We were all set there to measure the size of these prostates. It did not take a statistician to show the difference. I mean, the 3 other groups had small prostates, and the animals treated with a combination had very large prostates. And that proved to be a model that has been very valuable. It was used over the years, and after I came here, it provided the basis for our first program project on the study of prostatic diseases, a program project that we have used up to this time to provide funding for this work.
In 1974, you left Wilson's laboratory in Texas, and you came here to assume the direction of this department. How did you find it at that time when you first came?
Well, I think there's maybe many ways to describe it. Some people would say somewhat disappointing. I thought somewhat challenging. The building, first of all, was built in 1915. It was on a very small footprint. It was 8 stories high. It had deteriorated over the years. There were no private bathrooms. And when the search committee asked me if I could teach, do research, and operate, I responded affirmatively. When they told me that I was going to have to relocate to the historic Brady Urological Institute, I was really very worried about how I would do this. And what I had overlooked was the importance of my wife. I met Peg when she was in interior design school at Case Western Reserve. And while I was in medical school, she was an interior designer in Shaker Heights. And after we married, she moved to Boston, where she was an interior designer. And when we came to Baltimore, she set up in a firm here. And she proved to be the answer to this big problem. The building was poorly located. We couldn't expand it. We couldn't renovate it. And in looking around the campus, I found the Marburg building, the building we're in, and I realized it was being vacated. It was one of the original buildings of the hospital, built in 1889. It used to house the private medical and surgical services, but those services were now being transferred to the Nelson building. And I went to the administration and I asked them that if I raised the funds, could I have this building? Well, it was a real challenge renovating this building. But Peg had a real image for what it should be. She knew that the Brady Urological Institute, when it opened, had marble floors and Piranesi prints. And the architects here had no appreciation for what we wanted to do. But with her perseverance and style, we were able to renovate this building to what it is today. It's a wonderful place to work. It's been a wonderful place to continue discovery. And the faculty also wasn't very big when I came here. There was Dr. Scott, and there were 2 young members of the faculty who subsequently went into private practice. So the first thing I decided to do was I wanted to recruit a pediatric urologist. And I put together a search committee, and within a year, Bob Jeffs joined me. And I met Frey Marshall at a meeting. Frey was just finishing his residency at the Mass General, and he told me that his grandfather's name was Francis Patrick Walsh. Well, what could be a better reason to hire somebody? So in 1975, I had the 2 of them in tow. And the other thing was that Don Coffey was here. Don Coffey had his labs on the 5th floor of the building. His primary appointment, however, was in pharmacology. And so I asked him if he would direct the laboratories here. I made him a full professor. And so by 1975, we had Don Coffey directing the labs, and we had some very exciting work going on in cancer and in pediatric urology and in reconstruction.
So by 1975, the stage was set for serious work here. You had your initial faculty in place. You had concepts about designing the place and its appearance. You had a sense of the tradition. Your initial sense of training was fairly mature. At this point, you were starting into the major phase of your career, which really catapulted you to international success. This dealt to a large extent with the surgery for prostate cancer. Tell us what this operation for prostate cancer was like in those days, how it was that you realized that things could be better, because here I think lies some of the hidden information that people watching this interview, students, young residents today, this is the kind of information they're hoping to hear.
Well, let me back up one step, because it's important to say, how did I decide I needed to work on prostate cancer? And let me back up one step. When I came here, I decided that the most important reason to be here was discovery. Yes, we had to teach. Yes, we had to take care of patients. But we could teach better and we could take care of patients better if everyone discovered. And I also believed that everyone should find a focused area of opportunity. Bob Jeffs, it was very clear, reconstruction, pediatric urology. Frey Marshall came along. I asked him what he wanted to work on. He wanted to work on the kidney. Mike Droller wanted to work on bladder cancer. And so that told me that I had to work on prostate cancer. It also told me that I needed to find an area where there was great need to make a discovery. And I picked prostate surgery. Why? Radical prostatectomy was developed here at Johns Hopkins by Hugh Hampton Young in 1904. Yet 70 years later, the operation was rarely performed. As a matter of fact, in those days, if we did 10 a year, that was a lot. Now, you know today, there are over 800 a year done at Johns Hopkins. It is the most common inpatient operation done at this hospital. Well, why wasn't it being done? People believed that it cured cancer, but they believed that the side effects were actually worse than the disease. Every man who had the operation was impotent. Many men had severe incontinence, and there was tremendous bleeding. So I decided I would begin to work on bleeding. Everywhere I had been, Cleveland, Boston, Los Angeles, San Diego, Dallas, Texas, every time I saw these operations performed, there was tremendous bleeding, and no one ever mentioned it as being a problem. I had seen the great Willett Whitmore operate. Same thing. So I used the operating room as my anatomy laboratory. And over the next several years, every time I did a radical prostatectomy or a cystectomy, I figured out the anatomy of the veins around the prostate. And actually, that's going to be the answer to all of the discoveries I made about the operation, is everyone thought they knew the anatomy because they knew where the prostate was. What they didn't understand is the anatomy of the tissues around the prostate. So by 1977, I was able to control the bleeding during this operation quite well. And a 57-year-old man came to see me from Philadelphia. He had prostate cancer, had recently remarried, and said that he wanted to have a radical prostatectomy. And when I told him that he would be impotent, but there were ways to treat it, he said, that's how I want to be treated. Well, he returned for his 3-month visit, and I said, let's talk about how we're going to treat the sexual dysfunction. He said, what dysfunction? He said, I'm fully potent. Well, the bell went on, and let me back up to Claude Beck. Claude Beck had told me when I was a medical student, he said, listen to your patients. That's where you'll make discovery. So I began to wonder about this patient, and I wondered, if he was potent, why is anyone impotent? Why isn't everyone potent? Well, the common knowledge at that time was the nerves responsible for erection in men traveled through the prostate, because every time you took out the prostate, men were impotent. Well, I knew that either the anatomy in this patient had to be different or that I did something different. So you were a resident then. Remember how we went to the library, we pored over every report we could find. We wrote to an anatomist, I think in Poland, to try to get some advice. And there was no knowledge about where these nerves were located. Well, I tucked that problem in the back of my mind, and in 1981, I was invited to the Netherlands to give a talk at a meeting. And Peg hadn't been to Europe yet, so it was a chance for her to see Europe. And I was promised that I would be doing this traveling and visiting places. Well, after 5 days, I had been in the operating room, a lecture hall, and a laboratory. And finally, it was Friday, February 13th, 1981, my 43rd birthday, ironically. And they said at noon, well, you're going back to the United States tomorrow. We would like to show you around Leiden. And we've selected Dr. Donker to show you around. And the reason they picked Peter Donker is that a number of years earlier, at a meeting, I had befriended him and got to know him. Well, he was the retired professor, and I was interested in what you do when you retire. And I said, what are you doing these days? He said, well, I'm working in the anatomy laboratory. He said, now wouldn't you like to go see the windmill museums or the canals? And I said, no, I'd like to go see what you're doing in the anatomy laboratory. So we went to the basement of the anatomy building, a beautiful building with a museum. And Peter takes out an infant cadaver and a dissecting microscope and his drawings. And I said, what are you doing in the anatomy lab? He said, I'm dissecting out the nerves to the bladder. I said, why are you doing that? He said, well, actually, no one has ever dissected them out precisely before. I said, why are you using an infant cadaver? Well, he said, you can't find these nerves in an adult. There's too much fibrofatty tissue. There's distortion from the postmortem state. The fat that you use to dissect away has been dissolved away by phenol. He said the infant cadaver is perfect for this, and the nerves are correspondingly larger. Well, when I looked at his drawing of the pelvic plexus, and I looked in that dissecting microscope, I said, where are the branches to the corpora cavernosa? He said, well, I've never looked. And so we spent the afternoon dissecting out those nerves. And by the end of that afternoon, it was very clear that the nerves were outside the prostate, outside the capsule of the prostate, that it was possible to preserve them. So over the next year, he did more dissections, and I came back here and studied the patients. And a year later, we met and went over the anatomy. And there was a beautiful schematic available in the infant cadaver. But the real question was, how could you translate that anatomy to the adult and find it during surgery? And in looking and talking to Peter, it became clear to me that there were some vessels that ran just outside the prostate, the capsular arteries and veins of the prostate. And during the year that we had been apart and I was doing dissections, I noticed that these vessels ran in close association with where the nerve should be. And so it made sense that that neurovascular bundle might well be the macroscopic landmark necessary to identify these nerves. So I returned to Baltimore in March 1982 and did a radical cystectomy on a 67-year-old man. I'd never had a patient potent after cystectomy, and he was potent 2 weeks postoperatively. And then on April 26, 1982, I operated on a 52-year-old professor of psychology from Cleveland, and within the year, his sexual function had returned. And today, 17 years later, he is free of cancer and doing well.
Pat, this is the medical equivalent of striking gold. When you found this, you knew you had something wonderful. How did you present this, and how was it received?
Well, you know, it was a little surprising. I mean, I really thought it was wonderful that I would teach people this and I would go off and work on something else. And I found a lot of skeptics. And as I sort of recovered from that reaction, I began to realize that, sure, radical prostatectomy had been done for 70 years. Every man was impotent. All of a sudden, somebody comes along and says, that's not true. And everyone said either what I was saying wasn't true, or that I must not be doing a very good cancer operation. And so what I've been doing, and you've been working on, all of us have been working on over all these years, is to show that it is a good cancer operation. It's actually a better cancer operation than we used to be able to carry out, and to prove that and teach everyone how to do it. There were other discoveries that came along. Herb Lepore did a beautiful study showing that indeed the neurovascular bundle contained the nerves. Peter Schlegel showed that back near the seminal vesicles, where you didn't have the neurovascular bundle, there were landmarks that could also be used. Today we are still perfecting this operation. But in a patient-reported series that I just completed, at 18 months, 93% of the patients state that they are completely dry, and 86% of the patients state that they are fully potent. And that really is the reverse of what the results were 20 years ago.
Several other coincidental, very important things happened towards the end of the 80s. There was the discovery of prostatic-specific antigen, the recognition that prostate cancer was widespread, that it could be identified at an earlier stage in young men, and this created the opportunity to treat many younger men and to provide a tremendous amount of information and exposure to patients and their families. This set the stage for what I think we could consider the second major discovery that's taken place here, related to the inheritance of prostate cancer.
Well, as a result of doing this operation, a lot of young men came to see me. And over again, they would mention that they had a family history of prostate cancer. Well, many people had heard that and had dismissed it as saying, well, prostate cancer is very common. But a particular patient about 12 years ago came to me, 49 years old, and he said that every male member of his family had died of prostate cancer, his father and his father's 3 brothers. And here he was at age 49. And I began to wonder about why we didn't know more about hereditary prostate cancer. I had heard and read a paper that in Utah there was a clustering of prostate cancer, which I attributed to sort of the Mormon population of men possibly being inbred. But I wondered, I mean, if you stopped a woman on the street and you said to her, if your mother or sister has breast cancer, what is your risk of developing the disease? They would tell you it was 2-fold increased. And here I was the chairman at Hopkins, and I didn't know what the risk was associated with a family history of prostate cancer. And so I set out to study this. And here again, my patients played a big role in this. I took 600 consecutive patients and did a case-controlled study using patients and their spouses. This involved a 20-page questionnaire, and each one of them had to complete a 45-minute telephone interview, and we got a 95% response rate. Now, this work would not have been possible without some of the great people here at Hopkins. Gary Steinberg was my resident at that time. Bob Carter, an MD, PhD student in the School of Hygiene, came in and did beautiful work. He brought along Terry Beatty from the Genetic Epidemiology Group, Barton Childs, a pediatric geneticist who had been my longtime friend, and subsequently Billy Isaacs and Sally Isaacs came in. So all of a sudden we knew that prostate cancer ran in families and that it had an inherited tendency that looked like it was an autosomal dominant trait. The next question is, could we find the gene? And that's where the hunt has really been exciting. Bill Isaacs, who was working down the hall on the molecular genetics of prostate cancer, joined in. We expanded our families. I convinced Parade magazine to publish an article on this, and from that we got 2,000 hereditary prostate cancer families. So armed with our 2,500 families, we teamed up with the group at the NIH, Jeff Trent and Francis Collins at the National Center for Human Genome Research. And within a few years, we have identified hereditary genes on chromosome 1 and on the X chromosome.
In addition to amassing all this data and making these discoveries, you've been a champion for patients with prostate cancer in several ways. I can think specifically many times at the podium of national and international meetings when you've addressed the issue of the older man who has advanced prostate cancer. And I remember specifically your words that you believe that at one time a 70-year-old man with advanced disease was once a 50-year-old man with curable disease, thus challenging widespread concepts throughout the world that prostate cancer is an untreatable disease or a disease that does not need to be treated. And as part of this, you've written a book which is for the ordinary person who has this disease, a book that offers them a chance to see something of their problem illuminated, to obtain some reassurance and to seek the best possible medical help. Tell us how this book came about.
Well, Janet Worthington was the editor of the Hopkins Medical News, and she came to interview me after her 53-year-old father-in-law died of prostate cancer. And she was totally distraught. And so she went and interviewed the other people in the department and put together a beautiful story. And we received more letters than any other article ever written for that magazine. And that convinced us that there was a need to have a book out there. So Janet, who's a magnificent science writer, and I decided to write a book, The Prostate, A Guide for Men and the Women Who Love Them. Because we realized that there were many men that wouldn't read this book, but their wives, their sisters, their mothers, and their daughters would read it and would bring them from care. And it's sold very well, and most importantly, it's helped many, many people. It's very straight thinking about what to do.
Pat, you're leaving behind a wonderful legacy in terms of what you have achieved, what you've showed, the standards. There are young people watching this interview, people who perhaps have aspirations to be departmental chairmen themselves, to lead departments. What would you say to these young people?
If there are resources to share with others, you have the opportunity to channel those to the areas that will provide the greatest benefit. And that is one of the wonderful things about being a department chairman. The other problem with being a department chairman, however, is making those resources available. And it involves not only organizing a department that runs well, being fiscally responsible, if you're a surgeon working hard, but philanthropy is a big part of it, and it's a big part of what I do every day. It's a wonderful challenge, and if you find an institution that wants someone to come in and do those things, then I don't think there's a greater position in the world. On the other hand, today, those resources aren't available everywhere. And for some people, it may be that if you're in a place where you are making a contribution, where you are happy, that might be a better choice of careers than just to have the glory of being a department chairman for 5 minutes and the responsibility and problems for the rest of your life.
Very early in your life, already as an undergraduate student, you were fortunate enough to meet your wife, and I think you've been very lucky with a very happy and supportive family. Tell us a little bit about your family. Certainly we all know your wife's a very important role in the department here, but tell us from your own personal point of view.
Well, Peg is not only important to the development of this department physically, but also philosophically, because she has shared with me her own views about many of the philosophies that I hold, and we both ascribe to them very strongly. We've been very lucky to have 3 wonderful sons. I have a picture of my family right here. 2 of our boys were born in Boston. 1 was born in Los Angeles, and they've all done wonderful things here. Christopher was the historian who went down to the basement in the old Brady building and brought up all of the archives from Hugh Hampton Young, including some of the portraits that hang here, and had them restored and put together the Hugh Hampton Young archives. He did this when he was just a young man. Jonathan made a very important discovery in the lab with Don Coffey, looking at dihydrotestosterone's effect with estradiol on kidney growth. And as a result of those interactions with Don, Jonathan's getting his PhD in cancer biology at the University of Chicago. And Alexander is our computer whiz who put together the database here, put together the original method for looking at nuclear roundness, and as a result of that has gone on into medicine and has entered the field of ophthalmology and is very interested in product design engineering in the field of ophthalmology. So Hopkins has had a big impact on them, and they've had a big impact on Hopkins.
In addition to all the discoveries, to the direct contact with people, you've built up a department that I think is the pride of the institution and is the envy of many departmental directors around the world. I know that you have a certain philosophy regarding leadership and regarding the development of a department of this stature. Tell us what this is.
Well, I think you need a philosophy, you need a template, because as a clinician, as a surgeon, every day there's more to do than you can possibly do. And over time, I sort of simplified that template into 3 simple things. First of all, we had to be here for discovery. That was the major reason for us to be here. And to implement that discovery, I sort of simplified 3 philosophies on top of it. First of all, that less is more. Secondly, that if you're going to do one thing well before you do the next thing. And the final piece of advice was a piece of advice that Dan Nathans gave me, and that is you only make important discoveries by working on important problems. So what we've tried to do in this department is to identify the important problems, to work on those important problems one by one, and to do one thing well before we did the next thing, and to be satisfied that less is more. We didn't have to do everything. And I think that piece of advice has sort of been the template for our department. We just try to do things well. I've been blessed with wonderful faculty members. Imagine coming to a department that had a Don Coffey. I mean, Don Coffey is the Renaissance scientist, the leading scientist in the field of prostate diseases and prostate cancer. And he independently has pulled together a wonderful group of scientists that work side by side with us. We have, as you know, the way we designed the department, our offices and our laboratories side by side. You hear people talk about taking things from the bench to the bedside, and that's very important. But it's equally important to take things from the bedside to the bench. And I've given a couple of examples of how problems that patients have brought to me, I've taken to the anatomy lab or to the genetics lab. And so having scientists and surgeons side by side has been wonderful. But I've been surrounded by great people like you and the other members of this department who I've just given a focused area of opportunity and let you work on it. And finally, there's something very special about Johns Hopkins. When I first came here, I remember going to lunch one day and sitting next to Vernon Mountcastle, the distinguished neuroscientist, and introducing myself as the new urologist, and expecting, like I had in other places, for him to say, oh, you're the new plumber. That's not the response I got. He looked at me very seriously and he said, what research are you working on? And I believe that for all of us that work at this institution, that we believe that we're called to a higher calling than just our profession, that we are here to discover. So I think being here at Hopkins, I have been able to make a contribution greater than I would have at other places. It's the expectation, and it's the opportunity, and it's the people that Hopkins attracts.